An excellent presentation that I'm sure will be very valuable to any dentists that perform endo treatment. See you soon.
Hi everyone, thanks for tuning in. The title of my presentation today will be Doctor, How Long Will My Root Treated Tooth Last? My name's Omar from Sydney. I'd like to introduce myself. Originally I was born in Christchurch, New Zealand, in the South Island of New Zealand there, and I did my undergraduate degree at Otago University in the far south of New Zealand, the South Island down the bottom there. When I finished my undergraduate degree at Otago University, I went back to Christchurch where I worked as a general dental practitioner for about a year, and then after that I moved to London in the UK, where I had many happy years working as a general dental practitioner there on the NHS and privately before I started my specialist training at King's College in endodontology. I also completed the membership of restorative dentistry exams through the Royal College of Surgeons in Edinburgh, Scotland. Currently I practice at Specialist Endo Crow's Nest in Sydney's North Shore. I'm also the administrator for the Facebook page, and I currently work at Sydney Dental Hospital treating the state waiting list of New South Wales. So this is a common situation. Patient comes in with a tooth that's been root canal treated many years ago, in fact 10 years ago. Tooth 2-6 hasn't been crowned, but it's been restored with a composite mesoocclusal restoration, and we're looking at this tooth and we're wondering whether we should sway the patient in favour of extraction of the tooth or maybe redoing the root canal treatment and crowning the tooth. So how do we decide on these factors? This is what the talk's going to be all about today. It's a very common scenario in practice. The patient will eventually ask, how long is my root canal treated tooth going to last if you do all this treatment? So this is the patient with the buccal swelling. So the patient comes in, 10 years ago the root canal was done, and they've now got a buccal swelling associated with tooth 2-6. You can see on the radiograph there's periapical disease on the radiograph associated with mesiobuccal, distobuccal and palatal roots. And then we open up the tooth and there's a hairline crack associated with the palatal aspect of tooth 2-6. We find the MB2 canal was not located. Around 95% of upper first molars apparently have this canal, and it's very common to have it. It could be a cause of failure in the future if you don't find this canal. So we do all this and we're worried about, again, the fracture in the tooth. Again, another situation where we might be considering to extract the tooth. So what do we do? That's what the talk's going to be about. So more about this tooth later on. But the common scenario we all face in practice is that our patient has been up for a long time, often with a sore tooth, and we say to them, you're going to need 2 to 3 visits to do this root canal treatment, maybe more. Sometimes you can do it in one visit, but sometimes if you're going to have a difficult treatment, then it's going to be 2 or 3 visits, and then you're going to need a crown. So that takes a couple of visits often. And it's amazing that more of our patients don't opt for extraction when we give them this scenario. But obviously they know that's what's good for their health and they want to keep the tooth quite often. So questions you may have been asked before by patients, I've certainly been asked many of these. If my tooth is dead, how does it stay in my mouth? They don't understand that the tooth may have periodontal ligament and alveolar bone attachments that are help holding the tooth in. You don't require a pulp for it to stay present in the mouth. They don't always understand this concept. If you remove all this tooth during the treatment, will there be anything left? They've looked in their mouth, they see the tooth's very broken down, they've had a root canal treatment done, or maybe they've got caries in the tooth, and they see that in their eyes they don't have much tooth left, but what they consider a little bit of tooth remaining is actually often and more than enough to restore the tooth. And they don't understand that by the time you say you're going to do all this treatment for them and even a crown, which involves more tooth removal, then there will be anything left to restore. They're worried about this situation. Isn't the prognosis of this tooth hopeless if it has no nerve? Again, they don't really understand the link between a pulp that gives the tooth sensitivity and the surrounding supporting structures that hold the tooth in place. So the nerve doesn't need to be there for obviously it to stay in the tooth, stay in the mouth. If the infection is so painful, how can the tooth be saved? Again, there's no correlation between pain and histological inflammation. In fact, if you have severe histological inflammation, doesn't mean it's more painful. It's all related to different things, like the threshold of pain the patients have. So they don't understand this, and if they feel that if they have the pain that's so bad, then the tooth may not be savable. And they're also worried about the pain not getting better, of course. And then they ask, it's not long into the consult where they say, "Doctor, how long will my root-treated tooth last?" They really are uncertain about the prognosis of what is going to happen. And the reasons why our patients ask these questions is really because they're worried about the financial and time costs versus success of the treatment. So they haven't got unlimited time, they haven't got unlimited resources, they've got families, they've often got other things to do, jobs that they'll have to take time out of to come and see us at the surgery, and they're worried that they're going to spend all this time, effort, and the treatment will fail. They're also worried that the pain won't get better. Of course, again, they feel that if the tooth was removed, then of course the pain will get better. They understand this, but they're really worried that if we do anything but extract the tooth, so if we offer root canal treatment and all this fancy stuff that we're talking about, that the pain won't get better. So this is a concerning factor for most of our patients. The other thing is that they're in denial. Quite often they've heard that a colleague of theirs, a work colleague, may have had something different done. It didn't need root canal treatment, but another dentist said it did, and they feel that there's an easier way out of the situation than doing all this treatment that you've spoken about with the consult visit. But what is the patient really asking us when they ask us, "Doctor, how long will my root treated tooth last?" They're not just asking us, how long is it going to stay there in their head? They're actually asking us a little bit more of a complicated question. So we have to think about what they're asking us and dissect that. And that involves many different factors in answering this question. So first of all, they ask us how long the tooth will remain functional as well as pain-free until it requires extraction or causes more pain. For them, extraction of the tooth is a failure and more pain is a failure. And they want a tooth that remains in function. They don't really care if the root canal treatment's healed and they've got a little root stump in the gum. They want a tooth that they can chew on. This is success in their eyes. It isn't just success of the root canal treatment, it's success of the prosthodontic restoration as well. Therefore, we look at 4 factors. Obviously, the first one that's really important is the amount of remaining dentine. If the tooth that we're going to treat hasn't got any remaining dentine, then we may as well not bother restoring the tooth and doing the root canal treatment, because the treatment will ultimately fail. So we've got to look at prosthodontic prognosis as a big factor. The other one is the supporting tissues holding the tooth in place. Of course, periodontal disease and lack of supporting tissues will be a factor in perhaps retaining the tooth long term. So this is something we also need to look at. Again, if the tooth is going to exfoliate or it's got progressive periodontal disease around it, maybe then we should opt for extraction. Also, the ability to eliminate the infections from the root canals, or the endodontic prognosis is very important. We have to be able to get all the way down to the apex of the tooth and clean it all out and disinfect it. We know that from studies that if we aren't able to do this, most of the time our treatment will fail if there is active infection within the root canals. This is called the endodontic prognosis. And then the 4th one is the patient factors. Medical history, parafunction, whether they grind on the tooth, lifestyle factors like whether they smoke, whether they've got an unhealthy lifestyle, have they got reflux, all these sort of things play a role. If they have reflux and acid erosion, this can play a factor obviously in tooth surface loss, and these are very, very important factors. Again, if they grind on the teeth, more likely they're going to wear the tooth down or crack the tooth eventually. And what we do in our head is we look at all these factors on the radiograph, in the mouth, patient factors, and we add them all up in our head and we come to a conclusion that we're either going to keep the tooth, redo the root canal, or root canal treat the tooth, place a crown, or restore the tooth in some way, maybe an onlay, and we get an answer. Or we're going to sway them towards having the tooth out if we feel that things are against us. So, for example, prosthodontic prognosis of tooth 1-5 here I felt was a little bit poor. Unless we do something like apical surgery or extract the tooth, we're going to have to deal with the fact that we want to remove a cast post and crown from tooth 1-5, and certainly the research that I did at King's on tooth loss during root canal treatment and post preparation would indicate that you wouldn't have much tooth remaining if you were to remove everything from that tooth. Then you've got a chance of fracture, so you subject the patient to a root canal treatment again after removing all that, and then you subject them to another post and crown, and ultimately they're probably going to end up with a root fracture of the tooth. It depends on how long they get out of that, of course, whether they're happy or not, but ultimately they'll probably end up with a root fracture at some point. You've got to look at tooth 1-4 as well, which is obviously very broken down and has its own restorative problems. So prosthodontic prognosis of this tooth not terribly good, and I might be considering apical surgery or another option for tooth 1-5 if the patient goes ahead with the treatment. So that's just something to bear in mind. Why are the prosthodontic factors actually important? Well, of course, root fracture is a very common failure of root canal treated teeth. In fact, it's one of the most common reasons why root canal treated teeth actually require extraction. The fracture resistance of a tooth is generally proportional to the amount of hard tissue remaining, and the region in which the hard tissue is lost is also critical to fracture resistance. So if you have a tooth with a mesioclusal and distal restoration rather than just an occlusal, of course the flexure of the cusps is more, and you risk root fracture more readily. Root and crown fracture, should I say. And also we need that 1 to 2 millimeters of ferrule so that we can stabilize the coronal restoration. Something the crown actually will grab around so that it stabilizes itself, so that it can actually hold the tooth together and prevent fracture. If we just have a very limited ferrule, obviously eventually you end up with decoronation of the tooth in the long term, or maybe leakage of the crown, and then of course reinfection of the root canals occurs. So prosthodontic factors are probably one of the most important things that we have to look at. If the tooth's not restorable, we can't do the root canal treatment and crown the tooth and restore the tooth adequately. Periodontal prognosis or periodontic prognosis is also an issue. For example, if you have teeth like this and the disease around them is progressive and the patient's unhealthy, or they've maybe got some immunosuppression, that disease will progress and eventually they'll lose the teeth. So they may have a really nicely root-filled tooth, but that doesn't matter to them if the tooth's been exfoliated. So what we need to do is pick up the periodontal probe. It's the first thing I do generally in a consultation, and I just check around the tooth quickly for any active disease or any suppuration coming from any pockets, any bleeding, and just see the general condition of the region that I'm treating. Periodontal pocketing around the tooth that you treat should be ideally less than 2 millimeters or so. If it's more than this, when we consider doing some more sort of periodontal treatment to try and control the disease, perhaps monitor the situation for a while before we go ahead with the treatment. Any narrow or deep pockets obviously may indicate a root fracture. What happens here is quite often the bacteria will colonize the root fracture, the little hairline crack, and you end up with inflammation just in the line of the fracture. So it's very difficult to find the pocket. Often with periodontal disease, of course, the pocket's quite wide and you can probe it very easily. But sometimes with these narrow fracture pockets, we have to kind of angle the probe and get in the right angle, and then you realize that the defect goes all the way down to the apex of the tooth or near the apex of the tooth, and then you realize that you're dealing with a root fracture, not periodontal disease. Again, another clue for this is to look at the contralateral tooth and see if they've got any periodontal disease around that tooth or the teeth around it. If they have periodontal disease, it's highly likely that maybe the pocketing may be due to periodontal disease. If they have no periodontal disease anywhere but one deep pocket around one tooth, it's unlikely they've got periodontal disease around one tooth. But there are always exceptions to that rule. It's just a little guide I follow. So endodontic prognosis, this is where we come in. If you have the experience and the tools to do the job, you can do almost anything nowadays. Tooth 1-6 was referred in to me. The previous clinician got nowhere near the apex of the mesiobuccal and distobuccal canals, and the MB2 obviously wasn't found. So there was disease associated with the mesiobuccal root there. Then I was able to do the treatment with some Vortex Blue files and some ProTaper Next files, and get around the curve and then clean the canals out. So if you have the right equipment and the right tools and experience, then you'll get your job done. So cleaned it out nicely. That patient's now happy, out of pain. Tooth 3-7 with the S-curve and the mesial root has a deep restoration and periapical lesion. I was able to clean the treatment out, but again, if you haven't got the right tools or experience, you're not going to be able to do this. I was able to get down there with a ProGlider file and then get to the apex using Vortex Blue, and then finish off with a little O2 nickel titanium K file just to get the apical stops. So size 30 was used at the apex of that tooth. So how do we get successful root canal treatment? What gives us our success? Well, we know that unless there's a sinus tract or an acute episode, the bacteria are often found in the often not found in the apical lesion. So we don't often get extraradicular infection with our treatment, with our periapical disease. That's not that common, but it can happen. So bacteria within the root canals are the major cause of apical periodontitis. So if we remove the bacteria from the root canals, that correlates to success, and that was shown in a study by Sjogren in 1997, where they took cultures within the root canal with a paper point and found that if they got a negative bacterial culture, that the chance of healing was very high. If they got a positive bacterial culture, we can still get healing, but it's a lot less chance of healing. 68% of their cases with a positive bacterial culture healed, and over 90% without a bacterial positive with a negative culture were healed. So patient factors, what do we look at? Of course, medical history, things like dry mouth or medications they may be taking, bisphosphonates, these kind of things. Dry mouth, of course, may subject the patient to caries or other oral diseases. Anything that will allow disease to flourish is a problem for our tooth if we're going to treat it. Again, we're treating a tooth, we've got to look at the whole patient as well. Habits such as smoking, drinking maybe if they've got reflux or vomiting or anything like that. Smoking obviously as far as their periodontal health is a big problem. These kind of habits play a role, but also they give us an idea of what the patient's care is like. Chances are if they're living an unhealthy lifestyle in other ways, they probably don't clean their teeth very well. That's just generally what I look at. Parafunction, of course, with regards to clenching and grinding. If they've got lots of previously cracked teeth and crowned teeth and they're quite young, then you might sort of come to the conclusion that they're doing something at night, they're grinding their teeth or clenching in some form, and this is a reason to protect the tooth more readily and perhaps provide some kind of splint to prevent them from damaging the tooth further. Obviously, there are things like lifestyle factors. They involve like stress, hard work. A lot of the patients that I've seen who have been very stressed have been caring for people who are ill. This kind of thing. This will increase the chance of fracturing teeth, stress, make their diet worse perhaps. They may have to grab meals when they can. And this will make the chance of caries or periodontal disease more likely. If they're not able to look after themselves because of these factors, then they may not look after their teeth or tooth that you're treating. So successful endo, we don't remove all the bacteria, obviously. There's many studies to show that, but we certainly limit and reduce the amount of bacteria within the root canal system. If we can remove as many bacteria as possible within the root canal system, we can move the disease within the root canal. We can lower the bacterial count and move the disease away from disease and towards a situation where health can occur, and we can get healing outside of the root canal. So the periapical tissues don't recognize that there's that many bacteria in the tooth and can start to heal again if we lower it. The inflammation, of course, will occur if the body feels that it's threatened, so we're moving it away from the body feeling threatened. The root canal system will be cleaned out, thoroughly medicated, and chemomechanically debrided. So as I said, we're moving the root canal from a situation where there's disease in it back to a situation where there's more healthy microflora within the tooth. That's why ultrasonics back in fashion. If we can move everything around and we can rip biofilms off the walls by acoustic microstreaming or cavitation, this will help us clean out the root canals more readily in theory. So the success of root canal treated teeth. What's the success rate? There's lots of studies being done on this, but the classic studies by Sjogren in 1990, they looked at the factors affecting the long-term results of endodontic treatment. The follow-up was 8 to 10 years, so quite a long follow-up. It was done at a dental school, and the success rate was fairly interesting stats here. If the tooth had no radiographic periapical lesion, then the success rate was about 96% of cases were remaining disease-free after 8 to 10 years. So very, very high chance that you're going to get a continued success. Of course, when we talk about success, we talk about continued absence of the periapical lesion in a situation where there's no periapical lesion, or we talk about healing of the periapical lesion if there is a periapical lesion. And they followed up the cases, as I said, for a long time, 8 to 10 years, so they were able to see the healing over time. So in these cases, there was no lesion, and 96% of the cases still had no lesion after 8 to 10 years. With a periapical lesion, the success rate drops significantly. 86% of their cases healed, so some of them failed, obviously. And the success of retreatment or healing of retreatment cases was 62%. So retreatment was very much lower than the previous criteria, and we're going to have a look at that in a minute. So the factors that they thought were important for success were obviously the presence of a periapical lesion is the biggest one, and that has something to do with the fact that if there's a periapical lesion, there has to be enough inflammation outside of the root canals or in the periapical tissues to perforate through the buccal or lingual plate. If it perforates through the buccal or lingual paint, then we get a lesion on the radiograph, and this shows up clearly. If it doesn't perforate through, then we end up without seeing an obvious lesion on the radiograph. So if we have a periapical lesion, what that really indicates is time, the ability for the bacteria to survive within the root canal, create a biofilm, and that takes time. So if the periapical lesion is present, that will indicate that disease has been set up, the disease network is now in place, and things have been set in stone. It's very difficult then to eradicate those bacteria. They're now in biofilms and protected, and they have their community going on inside the tooth. If that hasn't occurred, then chances are you can get rid of the disease more readily. They found that patients with advanced marginal periodontitis may be susceptible to failure of root canal treatment. The quality of the previous root canal treatment probably plays a role. Obviously, if the root canal treatment quality is quite good, or the obturation, I believe they're probably talking about, they probably don't know what happened in the disinfection of the root canal if it's a previous treatment. So if the obturation was of good quality, then it looked like the treatment was probably of a good quality, more difficult to correct. If it was a poor quality, obviously, then you can correct it and your chance of success may be higher. Previous perforation, obviously, if you have a situation where you can't reach the apex of the tooth, or it's transported and there's an apical perforation, then you're never going to be able to get back down to the end of the root canal and clean it all out effectively. And therefore the bacteria in that unclean part live on, and you get a failed treatment. And then if you have that situation, we need to think about surgical intervention if we're going to keep the tooth. The apical extent of the restoration, and they came up with the 0 to 2 millimeters from the radiographic apex. They thought that was the ideal length of the root canal, and if it was extruded, they found the treatments failed more. But we now know that perhaps we have to follow these extruded cases for longer, and they probably will heal, but it takes many years. There's a study by Fristad on that one, and it can take up to 25 years for these to heal. But the apical extent of restoration that they came up with was 0 to 2 millimeters from the radiographic apex as a guide. So we talked a bit about obturation and length of filling. So what do we actually get out of obturating the tooth? Well, of course, the main factor we consider with regards to obturation is coronal seal. We want to create a coronal seal. What that does is stops the ingress of microorganisms. Of course, if we're able to seal the coronal part, we don't need to fill the canals to get a successful healing treatment. What we need to do is create a coronal seal, but we all know that the coronal seal can break down over time. So by obturating the root canals, we actually just prevent ingress of microorganisms when that coronal seal breaks down, or when and if it breaks down. With regards to an apical seal, this prevents the fluid from the periapical tissues moving back into the tooth. If you imagine it's like a little beaker of water with a little tiny straw, the capillary action, the straw is the root canal. This capillary action will draw the fluid from the periapical tissues back into the tooth and feed the bacteria that have survived our root canal treatment. As I said, we don't get rid of every single bacteria in the tooth, and if they can survive on the fluid and they can live and they can multiply, then perhaps disease will keep going. So the theory is that if we create an apical seal, then we prevent the ingress of this periapical fluid into the tooth. But the other thing it does is it may prevent the toxins from leaving the tooth. Again, if there's a microorganism still alive inside the tooth and flourishing, it may prevent the toxins from coming out, entering the periapical tissues and keeping the body irritated and inflamed, which obviously is the disease. Do we entomb the bacteria? This is a very controversial topic, or entomodontics, as some people call it. We don't really know if entombing the bacteria helps us get a success. The theory is that it probably doesn't. We certainly can't just fill up the root canals and entomb the bacteria that way, but whether or not we get some success by filling the root canals and blocking off the bacteria from their community, we really don't know with regards to that. But chances are it probably isn't a major factor, but it may help in some cases. And really the other thing that obturation does is gives another operator or subsequent dentists looking at the case an idea of the quality of our treatment. I mean, obviously, if we haven't filled to the apex, we probably didn't clean to the apex. If we've filled poorly, maybe we didn't isolate the tooth well, or maybe we didn't bother about our treatment as well as we should have. So the idea is that if we obturate the tooth well to the apex, we've cleaned to the apex and we've densely filled it, then we've probably done the other stages of the treatment well as well. So why is there a different success rate in teeth with or without periapical lesions on the radiograph, as shown in Shogun's study? As I said, it's got to do with inflammation at the apical foramen, perforating through the buccal plate, and in order to get this we need a certain amount of time to have expired, and that means the disease is more established within the root canals. Sundquist's PhD, his PhD claimed that the number of bacterial species correlated to the lesion size within the root canals, and the lesion obviously was outside the root canals, but the bacteria inside the root canals correlates to the size of the lesion. Without the lesion, we don't have as much established disease, or that's the theory anyway. Or there may even be no disease in the tooth, of course, if there's no lesion. So you can get often these cases where there's a vital pulp beyond the root canal filling in the apical region. A lesion indicates the presence of significant disease and biofilms which are established in the canals. So biofilms are very resistant to our treatment, our cleaning and our shaping and our medicaments, and difficult to remove. And if they keep on going, then the disease will keep on going. We have to be able to break those biofilms up using our irrigants and medicaments and instrumentation. And if we do this, we have a great success rate in endodontics. So we've talked about the success or healing of periapical disease in ortho-grade treatment and a bit in retreatment, but we want to examine this retreatment situation again. There was a nice study done by Gorni and Gagliani in 2004, which was published in the Journal of Endodontics. They used 452 teeth. It's a mixture of lots of different teeth, and all these treatments they tried to do in one visit. They're all retreatments, all have periapical disease visible on a radiograph. They reviewed the tooth after 2 years, or the teeth after 2 years, and if it hadn't fully healed on the radiograph, the disease hadn't fully healed, it went down as a failure. So we all know that we can review cases for a lot longer than this and still consider them to be okay. Within 4 years would be acceptable. Longer than 4 years, if the disease is still present, it might go down as a failure. But there's always exceptions to that rule, but this is the general rule in endodontics. So they're looking at half this, and if it wasn't a success on the radiograph, the healing hadn't occurred, then it was a failure. So they're quite strict criteria on it. And they tried to do these treatments in one visit, but if the patient or the operator got fatigued, then they spent a second visit, and they used calcium hydroxide as the inter-appointment medicament, and they didn't use chlorhexidine at all to irrigate these teeth, just sodium hypochlorite and EDTA. The overall success was 69% of cases healed, so it's not very far away from the Shogun study, who got 62%. So you can see that this is a very common figure. You may ask your colleagues, what's the success of retreatment? They say 69, 70%, 60%, something like that. This is where this figure comes from. But when we break down the two groups, we find that 86% of cases where they were able to reach the apex and clean out the tooth really effectively, find all the canals. If you're able to do that, then the success was the same as if the tooth had not been treated before. As we saw in Shogun's study, what was the success with a periapical lesion with an untreated tooth? 86%. So it's the same. And these had periapical disease also. But if the anatomy is not respected, or they weren't able to reach the apex, there's a previous perforation or something that prevented them from reaching the apical foramen and doing a decent job, then the success of the treatment was 47%. So it was extremely low. So basically what this tells us is if in a retreatment case we can't overcome the technical difficulties that were there previously, which caused the treatment to fail, that the previous clinician wasn't able to overcome or maybe caused, then we may be looking at surgical or probably extraction of the tooth. Surgical intervention or extracting the tooth. So when the treatment fails, the ortho-grade root canal treatment fails, surgery is an option. It's a case that I did recently. The root canal treatment was done on tooth 1-4, and there was this lateral defect. You could see that was very difficult to clean out by ortho-grade means. There's a GP point going in the sinus tract that was present there, and I managed to lift up the flap, find that lateral defect, prepare the lateral canal using a ultrasonic tip, a small one, and I just leveled off the apex. I didn't do a proper apicectomy because the apical region had healed quite effectively, and also I just wanted to level the tooth, because if we cut the tooth off too low, then you're looking at going below that lateral defect, and of course it's a bridge abutment. We don't want to destabilize the bridge. So I just did a small flattening of the apical part and did a retrograde with MTA, and the lateral canal was filled with MTA as well. So that's during the surgery, that radiograph, that second one, and this is a year later. So you can see the bones nicely filling in there. Not quite healed yet, it's around a year later. So it's certainly an option if you have, again, if you have the tools, if you can get the diagnosis correct, the tooth's not cracked, you've got the microscope, you can see everything, and you're used to doing surgery, then certainly surgery is a good option for failed root canal treatment. So people talk about apical surgery and they say, no, it doesn't really work, and they see lots of failed cases, but what is the actual success rate of apical surgery? Well, one of the classic studies done was a short-term observation of endodontic surgery using super EBA. Of course, we've moved on to MTA and all sorts of other bioceramic material now, but Rubenstein and Kim, 1999, used super EBA. This is quite a good study. Some of the top surgeons in the world, of course, doing the surgery. And it was nice to see that in 94 cases, after a year and 2 months, 96% of their cases healed. And of course, with surgery, we get quicker healing because we remove all the inflammatory tissue directly. When we do orthograde root canal treatment, of course, we're waiting for that inflammatory tissue to resorb, and bone to come in. But when we physically remove that tissue, of course, the healing is going to be quicker. So after a year and 2 months, a very good healing rate. Large lesions took longer to heal, of course, because there's more need to have a bony infill, and granulomas took longer to heal than cysts. Then they did a long-term follow-up of these cases. So the ones that they considered healed after a year, they tried to bring them back. Unfortunately, they weren't able to get all of them back, but they were able to get a few back. It was published in 2002. 5 to 7 years after the case had been deemed healed, they managed to get 59 cases back. And then they found that 54 had remained healed. So their success rate after 5 to 7 years with apical surgery was 91%, which is a very good success rate. Again, they didn't bring back a huge amount of cases, but it shows you that apical surgery is a really good option. If you can do the surgery correctly, if you've got the right materials, if you've got the right equipment, if you can get the diagnosis correct, which is one of the common failings with apical surgery. Often there's apical fractures and all sorts of reasons why the tooth could be failing rather than just ongoing periapical disease, then we can actually get a good success rate with apical surgery. So don't discount that as a very good option. 5 obviously remained, didn't heal, and there was apical deterioration. So we've talked about success, and we know that success of root canal treatment, whether it be orthograde or root canal retreatment, is very good, provided we can get all the way down the canals and clean it out. So if we can carry out the treatment really well, then we can get success or healing of the disease, or maintenance of the disease-free status is very, very high. But what's the survival of root canal treated teeth? When we look at implants, a lot of the time there's talk of survival, whether the implant's present. So this terminology of survival has been adapted to root canal treated teeth. So when we look at survival of root canal treated teeth, what we're doing is comparing them to implants. That's the reason why this criteria was invented. There was a very large population study done by an insurance claims only by Salarabi and Rothstein in 2004, and they looked at 1.4 million teeth, so a lot of teeth, and they just did it purely on insurance claims or health fund claims, and they found that after 8 years, 97% of the teeth were still present. And some people may often say to me about the study, but what happens if the patient moved countries, moved health funds, didn't claim the extraction or whatever? Well, this may be the case, but 1.4 million teeth is a lot of teeth, and if it was a 90% survival rate, then we'd be very happy with that. That's a lot of people who've still got the teeth present because of root canal treatment. Of the 3% that failed, which is obviously still quite a decent number out of 1.4 million, 85% of these teeth weren't crowned. So what they're getting at here is maybe restoration of the tooth is important to survival of the tooth long term. Another study which I really liked was done by Ekebom. It was a 20-year follow-up of a Swedish population, and it was a fascinating study because he just sent out correspondence to 200 people or so, and they came in for full mouth periapical radiographs, and then what happened was 20 years later he sent out the same letter and said, please come in for your full mouth periapical radiographs, and 115 people turned up. So that's a fascinating number of people, really. To get that many people 20 years later to come back in for radiographic re-examination is quite some achievement. But it has some very nice stats in the study. One of them was that 71.2% of the root canal treated teeth were still present. So when a patient asks you, what's the chance of my tooth lasting or surviving 20 years, the chance is very high. 71% of these teeth. And you can sometimes say to them, the tooth next door hasn't had a root canal treatment, and it's not a 100% chance that that's going to be there in 20 years either. It's an 89.8% chance that your tooth will be there if it's not had a root canal treatment. So obviously the chance of an untreated tooth is better, but root canal treated teeth, the chance of root canal treated tooth being present is quite good. 20 years later is some length of time, obviously. Another study done by Aquilano and Capellan was just looked at dental records, and again looked at the reasons for failure of root canal treated teeth and how long they were around. Incisors, premolars and molars were all looked at. And basically they found that there was a whole lot of things they found, but one of the things they did find was regarding restoration, that teeth without crowns were lost 6 times faster. So if the tooth type and caries prior to access were excluded, so if they excluded the tooth type, because obviously some of the teeth wouldn't need crowns like the anterior teeth, but they looked at posterior teeth, and then they found that 6 times, if you didn't have the tooth crowned and it was a posterior tooth, it was lost 6 times faster than a tooth that was crowned. So that's something to say for restoration of the tooth. And what we're getting at with these survival studies is that restoration of the endodontically treated tooth is a very important part of survival of these teeth. So the latest survival study, hot off the press, 2014, it's done by Kirkevang. It's a Danish study. It's an observational study similar to the Ekebom study, the 20-year follow-up. It's 10-year follow-up. He looked at 8,666 teeth, 404 were root canal treated. There was a 10-year follow-up, and survival of percentage of teeth that survived after 10 years was 87%, so 13% of the teeth were extracted. So again, a very high survival rate. Not as high as the Ekebom study, not as high as the Salarabi and Rothstein study, but still quite high. And the survival of root fillings they looked at, so that means if the tooth was extracted or it had to undergo root canal retreatment, then 75% of teeth were still there. So extraction plus redoing the root canal treatment was around 25%. So again, our patients would consider that having to do the root canal treatment again would be a failure in their eyes, and extraction obviously is. So 75% is the stat we take away from here. They found that teeth with short fillings over 3 millimeters short or long fillings, and those with voids had the lowest chance of healing. Again, it comes down to the short fillings being under cleaned. We had that if you have filled short, you probably haven't cleaned to the apex, and there's residual bacteria remaining. If you overfill the tooth, you may break the apical foramen up and make sure that the seal is difficult to get. The apical seal that I spoke about might be difficult, and also it could leave the apical seal could leave space for the toxins to escape the root canals. With regards to voids, of course, again, that's perhaps the technical aspects of the treatment weren't carried out correctly, whether it be cleaning and shaping and filling all together. So when we know that the survival rate's quite high, we know that the success rate's quite high. Depending on what we do, obviously if we do the treatment correctly, we'll get a good success rate, we'll get possibly a good survival rate too, as long as we restore the tooth correctly. That's what we're getting the message through all these studies. But the failure of endodontically treated teeth was classified by Weyer in 1991. That's a classic study where basically he just removed some teeth that were root canal treated and classified why they were needed, why they required extraction. So just 1 year in a dental practice. And this will tell us the reason why root canal treated teeth require extraction. 59.4% of the teeth that failed were prosthetic failures, or teeth that were basically crown fractures or even decoronations, unrestorable teeth, and the 32% were periodontal failures or perhaps root fractures, and only 8.6% of the teeth that required extraction were actually removed because of endodontic disease. So you can see endodontic disease doesn't play a big role in extracting teeth. It's usually fracture of the tooth, root fracture or crown fracture, which makes the tooth unrestorable. So the take-home message of this is restoration of the endodontically treated tooth is a very important part of what we do in endodontics. We can do the root canal treatment really well, but if we don't restore the tooth, we may as well not bother. So why do the prosthodontic failures occur? There's lots of theories about why we get root fractures in teeth that are root canal treated more than vital teeth. Is it proprioception? Can we bite on these teeth harder without realizing it? If we remove the pulp, is there proprioceptors in the pulp? Is it dentines more brittle? Is it the irrigants that cause denaturation of the dentine? Is it the amount of hard tissue remaining? Proprioception, there was a classic study done by Rando and Glantz where they did loading of vital teeth and non-vital teeth. They placed crowns on these teeth and loaded them. There was only 3 subjects in the study, a very small study, and they basically were able to load up the non-vital teeth more with weights, and they were able to do double the amount of weights on the non-vital teeth to elicit some discomfort from the patient. The amount of hard tissue remaining, there's some interesting questions with regards to that. This is the most popular theory why root canal treated teeth fracture. But what we want to know about the hard tissue remaining is, does the root canal treatment damage the remaining tooth structure? How much does it damage it by? Does the access cavity remove unnecessary dentine, or is it the cleaning of the canals? What's the real reason? Is it the fact that the tooth's damaged to begin with? We don't treat healthy teeth generally. We don't generally do root canal treatment on healthy teeth. Usually the teeth are severely broken down, carious, or already damaged in some way. So what is the real reason? Does the cleaning of the root canals remove any dentine that's significant? And what stage is the most damaging out of all these stages that we do in root canal treatment? So this brings us to my master's thesis that was published in the International Endodontic Journal in 2009 on microcomputed tomography of tooth tissue volume changes following endodontic procedures and post-space preparation. And what we did in the study was we looked at premolar teeth that had distal occlusal or mesoocclusal caries that entered the pulp. So you can see picture A, we've got the caries in the tooth, this is the same tooth in every picture, and we've got the caries, and you can see the pulp exposure. Then in picture B, this is where the caries has been removed and the pulp's been exposed, and then C is where the access cavity has been prepared to get into the root canals. Then you can see in picture D, the root canal treatment's been carried out. The picture E is actually just a preparation of a post space using a fiber white post drill, so just a parapost kit. And then F, I've just removed the undercuts that would normally accommodate a cast post. So no extra preparation of the root canal was done in picture F between E and F, just the undercuts were removed in picture F there. So the aim of the study was basically to compare the volume loss at each stage and see what's the most damaging and how we can prevent this loss of tooth structure. So we extracted, obviously we got some human premolars that had to have class 2 lesions which went into the pulp, and we radiographed the teeth before we commenced the study to make sure that caries involved the pulp, and we measured the volume change at each stage. Two-dimensional view of the same tooth, so you've got picture A with the caries in there, and then we've removed the caries in picture B, then we've accessed the canals in picture C there, and picture D we've cleaned out the root canals and done the root canal treatment. Now it's very interesting to note that I used ProTaper F2 to finish the preparations with, and also Gates Gliddens to prepare the coronal aspect of these canals. So we've done a lot of preparation within the root canals. In picture F, just the post-space preparation. Sorry, picture E, the post-space preparation. Picture F, just to remove the undercuts that would accommodate a cast post if we were to place a cast post there. Of course, we didn't crown prepare these teeth because that would add another variable, so we just wanted to know before the crown would have been placed how much is lost. So obviously preoperatively that no tooth structure had been removed by operative procedures, so we put down 0 for that. after the caries removed, an average of 8.3% of the whole tooth structure had been removed. So these teeth were very carious. Even with an mesial-occlusal or just a distal occlusal restoration, nothing more than that, we had a lot of caries. We had a lot of tooth tissue removed from caries removal alone, just to make the tooth sound. So that's a significant factor. The other significant factor was the access cavity going down into the root canals. Just to go down in the root canals and expose those so we could instrument them after we'd removed the caries, that was actually a significant 4.4% of the entire hard tissue removed, including the root, the crown, and everything. The root canal preparation, or the physical cleaning of the root canals, didn't actually remove any significant amount of dentine. So just to prepare the root canals was not significant. That was the only part of the study that wasn't significant. Fiber post preparation of the root canal, just to get the fiber post space prepared, was significant, but if I'd had more samples, perhaps it may not have been. It's a very small amount, obviously. But this is the surprising one. In order to get the cast posts undercuts removed to allow insertion of a cast post, just to remove the undercuts was another 4.1% of hard tissue lost. So that's a significant amount of tooth structure to lose just to accommodate a cast post. That was the most surprising result in my eyes. The conclusions of the study were that if the flexural and compressive strength of a tooth are proportional to the amount of tooth structure remaining, then our study is very important. Of course, the access and post preparation caused the largest loss of tooth tissue, and cast post removes a significant amount of tooth tissue when compared with a fiber post. So when you think about restoring a tooth, using a fiber post is good, and obviously not preparing a post space and leaving the space that you've created when you've done your endodontic treatment is probably the way to go. So the less amount of preparation or post preparation is the best with regards to maintaining hard tissue and keeping the strength of the tooth. And obviously these situations need to be taken into account when planning restoration of root canal treated teeth, because if we can keep as much dentine as possible, then our tooth will survive longer. And if we can restore the tooth correctly, then we'll get a good survival also. So here's tooth 2-6 from earlier. The patient had the root canal treatment done 10 years before they had seen me, and has had the tooth present for another 6 years, because I'm still in contact with the patient. There's the healing of the periapical disease after just over a year, and there's the crown that I placed on it whilst I was doing my master's study at King's College. So she was very happy with the result, and it's been 16 years since the initial root canal treatment was done by the previous clinician, and despite the fact there was a fracture in the palatal aspect of the tooth still is there and surviving nicely. So she's very happy. She hasn't had to have an implant, and I'm very happy because it's been there for a long time. So when a patient asks, "Doctor, how long will my root treated tooth last?" what can you tell them? We know that root canal treatment done in an ideal situation using the best aseptic techniques available to us and a good sodium hypochlorite as an irrigant has a very good success rate. So healing a periapical disease is approximately 86% of cases with a periapical lesion on the radiograph. Survival of root canal treated tooth is also very high. You can get up to 97% of the teeth still present after 8 years, and that was shown in the study by Salarabi and Rothstein. So we know that success and survival can be really good. However, the most common reason for extraction of root canal treated teeth is in fact root fracture. So one of the best ways to minimize fracture is to minimize the amount of hard tissue lost and to restore the tooth correctly in a conservative manner. So we need to cover the cusps of those posterior teeth when we feel that is necessary, and we need to minimize the loss of hard tissue during the procedure if we can. So this technique is very important for survival, and it underpins our root canal treatments. Thanks for tuning in, and if you have any questions, please contact me on the details that I've provided there, or perhaps on the Facebook page. Thanks, and hope you enjoy the rest of the presentations.